This week on the BackTable Podcast.
If we think about a fighter jet, we know a fighter jet that has a smart bomb is going to be more strategic, more accurate, and more efficient at getting its target versus a plane that doesn't have those smart weapons. They sort of drop a bunch of bombs and just sort of hope you hit your target. And that's what I mean by thrombectomy by proximity. So devices that are guide wire based, it's sort of thrombectomy by proximity, where Alpha Vac is thrombectomy by selection. And being able to select your target, you can put maximum and complete suction on the embolic debris, and it's not a drive-by suction embolectomy. So significant differences.
When you're managing complex PE cases, every decision matters. Navigate with confidence using the Alpha Vac F1885 system, purpose-built to deliver control, precision, and safety during PE interventions. The Alpha Vac F18-85 system combines powerful targeted aspiration with a streamlined, steerable design to help you remove thrombus efficiently while maintaining hemodynamic stability and minimizing procedural blood loss. The Alpha Vac system's ergonomic handle and angled funnel tip allow you to tailor approach based on patient anatomy and clot burden, allowing physicians to focus on patient care, not system limitations. To learn more about how the Alpha Vac system is revolutionizing PE care and our cardiovascular portfolio, visit www.angiodynamics-cv.com or contact your local Angiodynamics representative. Alpha Vac, clot removal without compromise.
Hello, everyone. I'm your host, Sameh Sayfo, interventional cardiologist from Baylor Scott & White, the Heart Hospital Plano, coming from Dallas, Texas. I'm honored to have Dr. Sabah Butty, an interventional radiologist, coming to us from Indiana. Dr. Butty got his Jones surgery degree, actually, initially, and then he saw the light and he said, maybe, radiology is the way to go. So he ended up going back and do a radiology and then interventional radiology at University of Virginia. And then he's been an associate professor at IU since 2002, doing a lot of vascular procedures, focusing on VTE. He's a wealth of knowledge, and we're happy to have you, Sabah, today to discuss PE management.
Thanks for having me.
Absolutely. So let's start simple. Tell me a little bit about what interests you in VTE. I mean, VTE 10 years ago, not even 10 years ago, 6 years ago was a boring field. You could put patient on an anticoagulation and maybe IVC filter, and that's it. Tell me your story. How did you get introduced to the VTE world?
Yeah. Our program in Indiana really started about 15 years ago, and it's just sort of dumb luck. At the time, the director, one of the service line directors for the radiology department, came back from Mexico, had a PE. And so we're talking about 15 years ago, and the treatments that were offered to him were either heparin, but he was very symptomatic, and one of the surgeons wanted to do an open embolectomy. He wasn't for that. So he asked myself and one of my partners, Tom Kashani, hey, what can you do for me? Is there something that you can help me out with? And so we did some catheter-directed thrombolysis. He got a great result. And to this day, 15 years later, he's living a normal life. So that's how our PE program started, and we did quite a bit of catheter-directed thrombolysis, but similarly, as your experience may have been, 7 or 8 years ago, we made a monumental shift. We went from catheter-directed thrombolysis, and we were doing large bore suction embolectomy. And so we've done hundreds of cases. I think we have a terrific experience at Indiana with this disease process. What interests me about it is that I think it's sort of been the orphan disease when it comes to vascular care. I think a lot of attention has been given to arterial disease, but now is the time for venous thromboembolic disease to get the attention that it needs, for those patients to get the care that they need. And I think we're in the right time, and I would think we have a better understanding of the disease process. And I think we're just following the natural progression of how we're going to treat this. If we look at heart attack and stroke and we see how they have developed, we started out basically with medical means. We think about heart attack. 20, 30 years ago, we'd give them an aspirin and heparin, then we got thrombolytic therapy, and we've had some successes. But something's happened. Our endovascular skills got better. Our endovascular technology got better. Our understanding of the disease processes has improved. So with heart attack, the number one cardiovascular disease in the United States, we went from medical to mechanical methods. And about 6 or 8 years ago, I think we did the same thing with stroke. We went from, and it followed those same footsteps, medical, and eventually made ourselves primarily mechanical in terms of restoring flow. And I think we're at that same crossroads when it comes to venous thromboembolic disease, particularly PE. As I said, I think we have a better understanding of the disease process, and we have devices that are suited for this disease space.
You mentioned that when you started with a catheter-directed TPA, and I think this is a very familiar story for many of the audience who has been doing it more than 3 years ago. I think the first thing we had, McNamara catheters and then ecos. What do you think made many of us switch from catheter-directed TPA that worked, and I think we've all had successful story, you just mentioned one of them, to thrombectomy? What was the reason to shift therapy?
I think education, and I think it is attention to the disease process. Catheter-directed thrombolysis works, but it doesn't work efficiently, and it doesn't always work. Having a better understanding of the disease process, as well as what is happening with the patient clinically, I think has been the large shift going from medical to mechanical. And I think we have to think of short-term goals and long-term goals. To a certain degree, catheter-directed thrombolysis can achieve that short-term goal. In other words, we create a physiologic change, we improve those pulmonary pressures. Patients can be symptomatically improved, but they may not be to what they were before the embolic event. And I think with large bore mechanical thrombectomy, we also have those short-term gains or goals that we can meet, but I think we're better suited to achieve those long-term goals. In other words, if I can get rid of as much of that embolic debris as possible, then the negative effects or chronic effects of having pulmonary hypertension or pulmonary embolism, I think we minimize those and we get those patients back to what they were from a functional standpoint earlier and faster. And I think that we also have to shift our mindset in terms of what our goals are and what we're trying to achieve. Of course, we always, if possible, would like to decrease mortality, but at the end of the day, we are also providing a procedure or an intervention where there's a possibility for a functional improvement. So I think short-term goals, get the patient out of the hospital, improve their symptoms. But I think we should be shooting for long-term goals, get the patient back to what they were from a functional standpoint before the embolic event. And I think that's something that large bore suction embolectomy can do, because we have the capability of extracting or removing large amounts of embolic material regardless of its age. It could be hyperacute, or it could be chronic, or it could be somewhere in between. And sometimes catheter-directed thrombolysis does not work well for subacute or chronic debris, and it's just going to remain there, and then the patient has those effects of residual pulmonary vascular obstructive disease. So I think we tend to minimize that with large bore suction embolectomy.
I think you mentioned two things I want to bring back and maybe discuss a little bit more. One, you mentioned the percentage of more of a fibrotic, subacute, maybe chronic clot that we know that TPA does not work in. And second, so the question number one is, how often do you see that when you do mechanical thrombectomy? And the second question is, you mentioned briefly that there is more efficiency with mechanical thrombectomy on those patients. They don't need ICU bed. You can go on the next day or the day after, where with a catheter-directed TPA, usually they stay in the ICU setting. Can you make those comments? And you think how often do you think those two reasons play a role in the type of device we use?
Yeah, I think doing enough of these procedures, you're sort of going to expect to see a mixture of clot. And I think that's representative of the disease process. Venous thromboembolic disease is something that occurs over, typically for most patients, days to weeks in terms of the formation of that clot. And then, of course, the embolic event could be quite acute. I think my experience has been that when I remove the debris, the embolic debris from the pulmonary arteries, it's the minority of cases where it's just pure red clot. Overwhelming majority of the cases, it's mixed ages. You see red clot, white clot. And I think that is, again, I think we now have a better understanding of the disease process, and now we can say why TPA doesn't always work. Having the advantage of being able to remove that clot in total is a significant advantage for that patient, and in terms of their long-term cardiovascular health, as well as their functional abilities once they've left the hospital. And I think that's an important thing. So we talked about your second question is utilizing hospital resources. I think, with everything in medicine, we're trying to do things better and faster, and we're trying to achieve an excellent clinical result. And I think that's something that large bore suction embolectomy allows us to do. We can do it better, faster, and we can do it in a more economical fashion. We don't need repeated labs. We don't need follow-up angiograms. We don't need ICU times or minimal ICU times. Of course, there are patients that are, regardless of a successful suction embolectomy or thrombectomy, they need to go to the ICU, but the overwhelming majority of the patients do not need that. I think at the end of the day, when we talk about this, in the past when I was a fellow, to do a PE intervention was almost unthinkable. And if you were, it was a Hail Mary. That patient wasn't going to do well. But the reality is that this is an everyday problem, and we have a solution that is effective for these patients every day. So in the past, we didn't have that. We now have it. And in our hospital, this is a very routine procedure. It's probably a very routine procedure in your hospital as well. I think any high volume center or well-developed PERT team, this is going to be a very typical procedure. So it is an everyday problem that has an everyday solution, and we should always try and get the best clinical result possible and do it in the most economical way. And I think this is what large bore suction embolectomy has allowed us to do. And these devices work effectively because we're now more appreciative of the disease process, and we have really done a better job educating ourselves as well as our fellow clinicians.
I think your team has participated in many of the IDE trials. I think you and I were actually on many trials together. I see your name all the time. There's always a nice competition to see a familiar face, and we compete on enrolling these patients. And now we just had one true randomized trial that came out recently. We're expecting a couple more. From an interventional radiologist, interventional cardiologist, vascular surgeon, I think we don't need to be convinced that and the patient needs to get this thing treated. But what do you think the research and the science, what's missing? What are the things that you're looking for in the future upcoming trials? What are the things that we need to answer?
I think they're important because I think they're helping us understand and helping us prove what I think we sort of already have a good hunch in terms of what the outcomes are from this type of procedure. And so I think it's just reaffirming that we're doing something that is impactful on patients and makes a difference. And I think that the trials in the past, we just sort of focused on, I think we sort of had tunnel vision. We're just sort of, obsessing about 30-day all-cause mortality. But I think, some of these new trials that are coming to light are also emphasizing quality of life. We want to know what these patients are like once they left the hospital, because getting them out of the hospital is an achievement, but getting them back to what they were before the embolic event is really our ultimate goal. And so we have to know and be appreciative or cognizant of post-PE syndrome. So I think many of the new trials, or really where the data is going to be looking at, is what is the RV function like 6 months down the road? What is their 6-minute walk test? What are the readmission rates? What's their quality of life? Because these are things that are important for the patients. We really can't declare victory if we get them out of the hospital, but they're sitting in a chair dependent on HOMO2. That's not what we want. We want them to be happy with their life. We want them to be functional. And I think that's what some of these trials, I think it's sort of a different twist that we're seeing with these trials. And they're focusing on things other than just 30-day all-cause mortality or readmission rates or PA pressures. And I think those are important metrics that we should look at.
No, I can't agree more. We can't move the needles in guidelines without speaking the same language like our pulmonologists and the ER doctors talk, the 6 minutes walk and quality of life and other metrics. I think your team has been participating in many trials that we mentioned. You have a lot of the commercial devices. I don't think we have time to cover all of them. Tell me a little bit more about your experience with the Alpha Vac device. What are the kind of features that you've noticed that make it different than other devices, and what has been your experience with it?
Sure. So, I think that when we talk about device selection, I think we sort of have to go back to basics. I think sometimes we are considering devices not in their totality, but just a particular feature of them. So when I think of a PE thrombectomy device, what do I want to accomplish? Doesn't matter what the device is. I want to be able to remove as much embolic debris as possible, and I want physiologic relief. In other words, I want to help the right heart. Then the second thing that I'm going to look at when I'm considering a device is how efficient and how effective is it? And then thirdly, we can talk about blood loss or the necessity for it or blood return, however you want to look at it. To me, those are, as I listed, the most important things to consider. So when I look at a thrombectomy catheter, the reality is and this is my opinion, I believe that all these catheters will have adequate suction, whether it's syringe-based, vacuum-based, or handle-based with Alpha Vac. They're going to have enough suction power to remove that embolic debris. I think the question becomes, how do we do it? How do we get that angiogram that looks good at the end of the case? And that's what matters to me the most. So when I look at the devices, I want something that is going to be effective. So it has to have suction power, and it has to be effective, not only in suction, but how we engage the clot. So when I think about engaging clot and ingesting clot through the thrombectomy catheter, to me, what an important feature is, and I think it's overlooked, is what is the tip design like of that thrombectomy catheter? I would want the tip that offers me the largest or greatest cross-sectional area so that I'm applying as much suction to as much clot as possible. And I think Alpha Vac has the greatest cross-sectional area. The end or the funnel of the Alpha Vac device is 33 French. There's nothing on there that's larger. So your ability to engage a large amount of debris with a significant amount of suction, that catheter meets that requirement. The second thing that we have to think about is that when we do a thrombectomy, I think for patients that are not doing well, we don't want to really disturb the physiology that we're seeing with the struggling right heart. In other words, I don't think there's any distinct advantage in terms of being able to have massive suction where there's significant volume changes. So if I'm using a 60 cc syringe and I pull that, I think you're changing the physiology and you're not really helping an embarrassed right ventricle. And so one of the beauties of Alpha Vac is that you are being able to deliver adequate suction. If we do a 10 ml pull, it's going to be 13.8 pounds per square inch. And it's not much different if I do the 30 ml pull, it's 14.2 pounds per square inch. But the point that I'm making is that it's localized suction. So we really don't disturb this tenuous pathophysiology. Thirdly, Alpha Vac is truly in a separate class compared to all the other catheters. I think all the other catheters, they work by proximity. In other words, they're guide wire based or minimally steerable. So with Alpha Vac, you are able to select areas throughout the pulmonary vasculature, right side, left side, and you can be targeted in terms of being able to have localized suction, and you have the greatest cross-sectional area to ingest that debris within the catheter. So when I think of Alpha Vac, it really touches upon all the things that I like to see. I like something where I can remove the debris, I get physiologic relief, it is effective, it is efficient, it is localized, it is selective, and those are features that no other catheter has. And I think that the way that I would describe Alpha Vac, it may not be the best way to describe it, but if we think about a fighter jet, we know a fighter jet that has a smart bomb is going to be more strategic, more accurate, and more efficient at getting its target versus a plane that doesn't have those smart weapons. They sort of drop a bunch of bombs and just sort of hope you hit your target. And that's what I mean by thrombectomy by proximity. So the devices that are guide wire based, it's sort of thrombectomy by proximity, where Alpha Vac is thrombectomy by selection. And being able to select your target, you can put maximum and complete suction on the embolic debris, and it's not a drive-by suction embolectomy. So significant differences. The other thing that we have to think about when we introduce devices into the chest, many of these guide wire based devices, we're putting in stiff guide wires. And that stiff guide wire, again, is another variable that's going to embarrass a struggling right ventricle. And it's going to be torquing the mediastinum. So these are mechanical or anatomic things that we're doing that we have to be more appreciative of. And I think with Alpha Vac not having that stiff guide wire in the heart or the mediastinum or the RVOT is quite advantageous. So I think from a physiologic standpoint, a safer, or at least this again is my opinion, it's a device that I would want more so than others from a physiologic standpoint. And then lastly, we talk about blood return and blood loss. And I think that when we talk about this, we shouldn't make this the only feature that we consider when we're going to use a thrombectomy catheter. We have to think about, why are we returning blood? Are we returning blood because it is an enhancement for a procedure or a device, or are we returning it because it's necessary? And if we're returning it because it's necessary, then that may be speaking to the inefficiency of the catheter or the thrombectomy procedure itself. With Alpha Vac, even though blood return is not available, it is not something that I find to be necessary. And then typically in our cases, I think when I first started doing it, my first 5 or 8 cases, I probably was losing about 300 cc's of blood. Now, having done many more since then, our average blood loss is around 200 cc's, which I think is quite respectable. So then when we talk about blood loss, we have to think, is blood loss expected? And the answer is yes. With every thrombectomy catheter, there is no such thing as a bloodless thrombectomy procedure. All the procedures, you're going to lose blood. And so then the question is it manageable? And I think with Alpha Vac, it certainly is manageable. And it's manageable because I am controlling the blood loss. I am the one that is pulling the trigger or the handle on the thrombectomy catheter. I control it, and I can decide, do I have more room to go for thrombectomy? I'm not at the mercy of a syringe, and I'm not at the mercy of a vacuum. So I can control it, and I can minimize it with the 10 milliliter pulls. And then lastly, is blood loss the end all be all? So, there are many other clinical situations in medicine. For instance, if we have a patient that comes in with a gastrointestinal bleed, they come in with a hemoglobin of 14 and they have a bleeding event. Now they have a hemoglobin of 12. Are we going to transfuse that patient? No, we're not going to. And the same thing with the pulmonary suction embolectomy or thrombectomy. If that patient's hemoglobin comes in at they're 10, post-procedure they're 9, are we going to transfuse them? The answer is no. It is really unlikely that you're going to have major hemoglobin shifts with blood loss during a thrombectomy procedure, whether you have blood return or not. It's not that it's impossible, but it's really unlikely. And the patients that may need a transfusion, those are the patients that were presenting with typically chronic anemia. They're sort of on the border of needing a transfusion regardless. So I don't think that blood loss and blood return are the end all be all. I think sometimes we give them too much attention than what they really deserve. And I think sometimes looking at those features alone detracts from what we really should be looking at with a thrombectomy catheter.
One of the things that I see with Alpha Vac that's kind of interesting and what I'd like to get your input on is the ability to kind of change the angulation of the catheter. So some of the operators use Alpha Vac in cases when you have a PE and also you have a clot in transit where you can angulate it. Have you done cases with clot of transit with Alpha Vac, and if yes, what the experience has been?
So somewhat close to it. Fortunately, where we're at, our ability to get perfusion is easy. I think we have a good working relationship with the perfusionist and the cardiac anesthesiologist. So for clot in transit, or I should rephrase that, for right heart debris, we get Angiovac. Clot in transit, you absolutely can use Alpha Vac. We have used its sister device, the Alpha Vac F22, or the 180, for patients where there was right atrial debris, whether it be a tricuspid valve or clot in transit, and we've been able to do those cases quite effectively. So in a similar circumstance, do I think it works well? The answer is yes. Clot in transit, right heart debris, right atrial debris, endocarditis, these devices are well suited for that. But if we can, we typically will use Angiovac in those instances. But it is something that is well suited for the pulmonary vasculature. As you said, its ability to navigate without a guide wire. And that's really the important thing, because when we think about other devices, most of the pulmonary injuries that occur are due to the guide wire. And the other devices that are out there, when I think about the procedures that I've done with them, they tend to be very busy procedures. There's a lot of moving parts. There's a lot of things that are happening. And Alpha Vac is quite unique. The catheter itself gives you a lot of feedback. And you get feedback from the catheter by looking at what's happening with the funnel fluoroscopically. You get feedback by looking at the barrel near the handle. You get feedback in terms of what's happening or what's emptying into the waste bag. Understanding the nuances of the catheter will give you a lot of information what's happening during the procedure without having to do intermittent angiograms or what have you. But in addition to that, as I had mentioned, because it is able to function without a guide wire, your ability to get those hard to reach areas, whether it be the right upper pulmonary lobe, left upper pulmonary lobe, linear segments, or the distal left interlobar artery, or a very angulated distal right interlobar artery, they're very easy to manipulate and engage with Alpha Vac. And those areas, you're not going to be able to engage that easily or effectively with other devices. At least that's been my experience.
You brought up the topic about, this different segment that we need to go after. And I'm a believer of, leave no clot behind if possible with safety margin, of course. But the question, if you ask 10 very experienced operators in the PE space about the definition of a successful procedure, when are we done? Is it taking all the clot out? Is it the PA pressure? Is the patient hemodynamic? Is it the patient's symptoms? You get 10 different answers. What is your answer on this? When do you decide this is good, this is enough, I'm pretty confident I serve this patient the way it should be served? What are your criteria for end of case?
Great question. When do we call a thrombectomy done, or when is the procedure completed? We're going to get a lot of different answers on that. I think there are multiple things that I use in terms of whether I'm going to declare success or the procedure is complete. I think one of the things that we have to think about is that it's one of the things that I talked about earlier in terms of short-term goals and long-term goals. So one of the things that I always keep in mind, when I get this question or somebody asks me, a trainee or whoever it may be, is that, if I were to give you an example, somebody that has normal heart and lung function, if I occlude their pulmonary vasculature by 25%, we're going to start seeing an elevation in their pulmonary artery pressures. If I occlude it by 50%, we're going to see a significant elevation in those pressures. And if I occlude it by 75%, we're going to see, a really elevated right ventricular pressure, probably over 50 millimeters of mercury. So a right heart that's struggling quite a bit. So having those thoughts in my mind, even if I were to remove 50% of the clot, I don't think that patient's really going to get the long-term physiologic result that they deserve. So I agree with you that, I want to get out as much clot as possible within reason. And again, it's the same thing that I mentioned earlier about arterial revascularizations. We're going to get out as much clot as we want, because if we leave clot behind, that's only going to be ignite us for more clot to form. The other thing that I want to think about when we do these procedures is that we can't just say, how do they feel? Because these patients really aren't doing much. So they're not in a stress state. And I only want to say a stress state. They're not in their normal state. In other words, these patients are laying on the table. They're not doing a whole lot. And so, of course, they may feel better if we get some clot out. But the real test is, how do they feel when they're upright and they're walking the halls? And it may be a different story if we're leaving some clot behind. And then thirdly, we have to really look at the totality of the patient. What are their comorbidities? Do they have cardiac disease? Do they have COPD? Do they have lung cancer? Do they have chronic pulmonary hypertension? And in those patients, even in the acute on chronic situation, every little piece, I think, will make a difference. So I always try and get out as much clot as possible. And that's one of the reasons why I mentioned this idea of what do these post-angiogram thrombectomy cases look like when I use an Alpha Vac versus competitive devices. And I think the ability to get to that point and to do it consistently and successfully with just about any patient is something that we should shoot for. Now, if we're getting out as much clot as possible, are we spending 2 or 3 hours doing these procedures? I don't think you should be spending that much time doing it. I think, there's a learning curve. And then there are good devices and devices that have, significant advantages. So I think as that learning curve is established and we are appreciative of some of these devices with very unique features, the ability to do a very good pulmonary suction embolectomy in an hour or less is very achievable. And I think doing that is important. And then the last thing I would say is when we think about what our end game is, and I think they're going to differ whether we use catheter-directed thrombolysis or large bore suction embolectomy. In my head, if we're doing catheter-directed thrombolysis, the way that most people have done it is you may do a pre-procedure angiogram. Some do, some don't, depending on what your comfort level it is or how much you're going to rely on the CT examination. We check those pressures and we come back. For many patients or many proceduralists, we'll see what those pulmonary pressures are the following day once they've gotten the thrombolytic therapy. And if we see an improvement, most people don't do a follow-up angiogram. So the reality is we're doing catheter-directed thrombolysis. We're trying to get a physiologic change.
So Dr. Butty, thank you so much for the insight on the management, your expertise on different devices and technologies. Tell us about your protocol in terms of patient post-procedure follow-up. When do you see them in the clinic? After the discharge, what's your protocol?
Yeah. So we typically will see the patients about 30 days after their discharge. And what I'm looking for are several things. I just want to know, are they back to where they were from a functional standpoint? And if they're not, then I may think about getting, obviously a follow-up cardiac echo or repeat CT of the chest. We may do a duplex of the lower extremities to see if they've had another subacute or underlying embolic event that just isn't recognized clinically. I also want to see if they have associated symptoms, because we know many of these PE patients are going to have DVTs. I want to know if they have any residual leg swelling, or if their legs have not or have improved since being discharged from the hospital. But really the main thing is functional improvement. And, it's just simple, going back to basics, just doing a simple history and physical exam. And then I think we can make more complex decisions based on what that exam and that history reveals.
Excellent. So answering the question, why did this patient have PE is important, following hematologist, May Thurner evaluation. Thank you so much for very insightful thoughts. And really thank you for sharing with us your expertise on the technology and how we're advancing the field. And again, thank you for you and your team on all the work you do in research and advancing the science. Dr. Butty, looking forward to seeing you in a future meeting, and appreciate your time today.
All right, no problem. Thanks for the opportunity, and wish you the best, and we'll go from there.
Thank you so much for joining us on BackTable Cardiology.
If you have not already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend.
If you have any questions or comments, direct message us at _BackTableCards
on Instagram, LinkedIn, X, TikTok, Blue Sky, or YouTube.
BackTable is hosted by Hadi Lisha
and Sameh Sayfo.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for tuning in.
We'll see you next time.